Welcome to this presentation on indications for intubation. This session aims to equip you with the skills to identify when intubation is necessary, a critical decision that can be life-saving in acute care settings. We'll explore the primary indications for intubation, delve into airway assessment using the Lemon criteria, review laryngeal anatomy essential for the procedure, and discuss real-world scenarios. These scenarios will illustrate not only when intubation is the best course of action, but also when alternative oxygen support methods, like CPAP or BiPAP, might be appropriate. By the end, you'll have a robust framework for making informed airway management decisions. Introduction to intubation. Intubation involves placing an endotracheal tube into the trachea to secure a patient's airway. This procedure is vital for maintaining oxygenation and ventilation while protecting against aspiration, particularly in emergencies. The preferred technique in urgent situations is rapid sequence intubation, or RSI, which combines an induction agent, like etomidate or propofol, with a neuromuscular blocker, such as succinylcholine or rocuronium, to facilitate quick airway control while reducing the risk of aspiration. For example, in a trauma patient with a suspected cervical spine injury, RSI allows rapid intubation without excessive neck movement. Today, we'll cover the 5 key indications for intubation, how to assess the airway using the Lemon criteria, the laryngeal anatomy you'll navigate during the procedure, and practical scenarios. These scenarios will highlight decision-making, including when intubation is essential versus when alternatives like CPAP or BiPAP might suffice. Indications for intubation. Overview. Let's overview the 5 primary indications for intubation. First, failure to maintain airway patency occurs when the airway is obstructed or at risk of obstruction. Think of anaphylaxis causing throat swelling or trauma leading to facial fractures and bleeding. Second, failure to protect the airway is when a patient can't prevent aspiration, often seen with a Glasgow Coma Scale score of 8 or less due to reduced consciousness. Third, failure to ventilate involves inadequate carbon dioxide removal, such as in a COPD exacerbation with rising CO2 levels. Fourth, failure to oxygenate is when oxygen levels remain critically low despite supplemental oxygen, as in acute respiratory distress syndrome. Finally, anticipated clinical course applies when a patient's condition is likely to worsen, like in sepsis with impending shock. Each indication reflects a scenario where intubation can stabilize the patient, and we'll explore these in depth with examples next. Failure to maintain airway patency. Failure to maintain airway patency means the airway is blocked or at imminent risk of blockage, requiring immediate intervention. In anaphylaxis, an allergic reaction can cause rapid swelling of the tongue, uvula, or throat, potentially closing the airway within minutes if untreated. For trauma, consider a patient with a mandibular fracture or severe epistaxis where blood and tissue obstruct airflow. Foreign body obstruction, like choking on a piece of steak, is another classic example. Here, the Heimlich maneuver might fail, necessitating intubation to bypass the blockage. The purpose is to ensure air reaches the lungs by placing the tube beyond the obstruction. Clinically, you might see stridor, dyspnea, or cyanosis as warning signs. Intubation here is urgent, often before imaging, as delaying could be fatal. Real-world scenario: anaphylaxis and airway obstruction. Imagine a 35-year-old male with a peanut allergy who unknowingly eats a snack with peanuts. Within minutes, he reports throat tightness, develops stridor, a high-pitched sound indicating upper airway narrowing, and struggles to breathe. On exam, his lips and tongue are visibly swollen, stridor is audible, and his oxygen saturation is 92% on room air, dropping fast. This is a textbook case of anaphylaxis threatening airway patency. Immediate intubation is indicated because the swelling could progress to complete obstruction before epinephrine fully reverses it. You'd prepare for rapid sequence intubation with a smaller tube size, say 6.5 millimeters, anticipating a narrowed airway. Delaying for observation risks a can't intubate, can't ventilate scenario, which could require an emergency cricothyrotomy. Here, securing the airway trumps all else. Real-world scenario: mild allergic reaction. Now, consider a 40-year-old female stung by a bee. She develops mild wheezing and shortness of breath, but no stridor or facial swelling. Her SpO2 is 94% on room air, she's in mild respiratory distress, and her vitals are stable. This is an allergic reaction, but the airway isn't immediately threatened. No tongue swelling or stridor. Instead of intubation, you could start with epinephrine to reduce inflammation and trial BiPAP to support her breathing. BiPAP delivers positive pressure to improve oxygenation and reduce work of breathing, buying time for medical therapy to work. Monitor closely for worsening swelling or distress. If stridor or hypoxia develops, escalate to intubation. This shows how severity guides the choice between invasive and non-invasive options. Failure to protect the airway. Failure to protect the airway occurs when a patient's consciousness is impaired, increasing aspiration risk. A Glasgow Coma Scale less than or equal to 8, indicating severe unresponsiveness, is a common threshold. These patients often lack a gag reflex, making them prone to aspirating vomit or secretions. In intoxication, such as with alcohol or opioids, the central nervous system depression dulls protective reflexes. Think of a patient found unresponsive after a binge. Stroke can impair swallowing due to neurological damage, as seen in a patient with a brainstem infarct who drools and chokes on saliva. Intubation places a cuffed tube below the vocal cords, sealing off the trachea to prevent gastric contents from entering the lungs, which could cause aspiration pneumonia or ARDS. Look for drooling, absent cough, or gurgling respirations as clues. Real-world scenario: opioid overdose. Picture a 65-year-old female found unconscious at home, suspected of an opioid overdose. Her Glasgow Coma Scale is 7, pupils are pinpoint, and breathing is shallow. Classic opioid toxicity signs. Her SpO2 is 88% on room air, and she has no gag reflex when you test with a tongue depressor. She's at high risk of aspirating if she vomits, and her respiratory depression worsens hypoxia. Intubation is critical here to protect the airway and provide ventilatory support. You'd use rapid sequence intubation with, say, etomidate and rocuronium, and ventilate via bag valve mask until the tube's placed. Naloxone will reverse the overdose, but its onset, 1 to 2 minutes IV, may not be fast enough to avoid aspiration or hypoxia, so intubation takes precedence in this severe case. Real-world scenario: alcohol intoxication. Now imagine a 30-year-old male brought in after heavy drinking, responsive with a Glasgow Coma Scale of 12. His SpO2 is 95% on 2 liters nasal cannula, and he has an intact gag reflex despite mild respiratory depression from alcohol. He's at risk for aspiration but can still protect his airway somewhat. Instead of intubating, you could trial BiPAP to support breathing and reduce work of breathing, keeping him on his side to minimize aspiration risk. Monitor his Glasgow Coma Scale, oxygen saturation, and respiratory rate closely. If he deteriorates, say, Glasgow Coma Scale drops below 9 or SpO2 falls despite BiPAP, intubation becomes necessary. This case highlights how a higher Glasgow Coma Scale and preserved reflexes allow non-invasive support as a bridge. Failure to ventilate. Failure to ventilate means a patient can't expel CO2, leading to hypercapnia and respiratory acidosis. In severe asthma, prolonged bronchospasm exhausts respiratory muscles. Patients may hyperventilate initially but tire, causing CO2 to rise. A COPD exacerbation traps air due to obstructed airways, reducing effective ventilation and elevating PCO2, often seen with confusion or drowsiness. Neuromuscular diseases like Guillain-Barré syndrome weaken diaphragm and intercostal muscles, impairing tidal volume. Intubation connects the patient to a ventilator, which takes over breathing to normalize CO2. Look for increased respiratory rate and accessory muscle use, slowing breaths, or ABG showing PCO2 greater than 50 millimeters of mercury with pH less than 7.35 as red flags. Real-world scenario: COPD exacerbation. Consider a 70-year-old male with COPD presenting with worsening dyspnea and confusion, which progressed to a reduced level of consciousness, and there is concern that he may not be protecting his airway appropriately. His arterial blood gas shows a pH of 7.09 and PCO2 of 85 millimeters of mercury, acute respiratory acidosis from hypercapnia. His altered mental status suggests CO2 narcosis, and he's using accessory muscles but tiring. Intubation is indicated for mechanical ventilation to lower CO2 and stabilize pH. You'd set the ventilator to a low tidal volume, 6 to 8 milliliters per kilogram, and adjust the ventilator rate to achieve an adequate minute ventilation. BiPAP can be considered in some situations and is a great tool for COPD, but with his severe hypercapnia and altered mental status, it is likely too late for non-invasive support. Real-world scenario, asthma. Now picture a 25-year-old female with asthma, presenting with wheezing and shortness of breath. Her ABG shows pH 7.38, PCO2 38 millimeters of mercury, and SpO2 88% on room air, mild hypoxemia, but no hypercapnia. She's in moderate distress, speaking in short sentences, but not fatigued. A BiPAP trial with steroids and nebulized bronchodilators can reduce her work of breathing and improve oxygenation while medications take effect. Set BiPAP at, say, 10/5 centimeters H2O to start and titrate as needed. Watch for signs of worsening, like silent chest or rising CO2, which would prompt intubation. This case shows how early intervention with non-invasive ventilation can avoid intubation in asthma if CO2 remains controlled. Failure to oxygenate. Failure to oxygenate occurs when oxygen saturation stays low, despite maximal supplemental oxygen, reflecting impaired gas exchange. ARDS can occur from sepsis or trauma, causes diffuse lung injury. Patients might have SpO2 less than 90% on 100% oxygen due to shunting. Severe pneumonia consolidates lung tissue, blocking oxygen uptake, as in multilobar bacterial infection. Pulmonary edema from heart failure floods alveoli, preventing oxygen diffusion. Think of a CHF patient with pink frothy sputum. Intubation with mechanical ventilation, often using positive end expiratory pressure, recruits alveoli and boosts oxygenation. Watch for refractory hypoxia, SpO2 less than 90% on high-flow O2, or cyanosis despite therapy. Real-world scenario, ARDS. Imagine a 50-year-old female with COVID-19 pneumonia on a 100% non-rebreather mask with an SpO2 of 85%. She was placed on BiPAP without significant improvement. Her chest X-ray shows bilateral infiltrates, consistent with ARDS. Despite maximal oxygen, her hypoxemia persists, classic failure to oxygenate. Intubation is necessary for mechanical ventilation with PEEP to open collapsed alveoli and improve oxygen transfer. You'd use a lung protective strategy, tidal volume 6 to 8 milliliters per kilogram, to minimize ventilator injury. High-flow nasal cannula or BiPAP might help milder cases, but her severe hypoxia demands intubation. Time is critical. Prolonged hypoxia risks multi-organ failure. Real-world scenario, congestive heart failure. Consider a 60-year-old male with congestive heart failure, presenting with dyspnea and SpO to 89% on 6 liters nasal cannula. Exam reveals rales and jugular vein distension, signs of pulmonary edema. He's responsive, not fatigued, and his ABG might show mild hypoxemia, PaO2 around 60 millimeters of mercury, but no CO2 retention. Non-invasive positive pressure ventilation such as CPAP can offload respiratory effort and improve oxygenation, while diuretics like Lasix reduce fluid overload. Monitor for worsening hypoxia or fatigue, say SpO2 dropping below 90% despite CPAP or BiPAP or labored breathing, which would signal intubation. This case illustrates how non-invasive positive pressure ventilation bridges therapy in congestive heart failure when oxygenation failure isn't yet severe. Anticipated clinical course. Anticipated clinical course involves preemptively intubating when a patient's condition is likely to deteriorate, even if they're stable now. In sepsis, early respiratory distress or shock can progress to full respiratory failure. Intubating early avoids a crash. Trauma patients might need surgery or imaging, example as with lying flat for CT, risking airway compromise from swelling or bleeding. Progressive neuromuscular diseases like myasthenia gravis cause gradual respiratory muscle weakness. Intubation may be planned before complete failure. The goal is to prevent sudden decompensation, like a trauma patient obstructing mid-procedure. Look for trends: rising respiratory rate, falling oxygen saturation, or worsening vitals. These decisions hinge on the art of medicine, where clinical judgment balances data trends with nuanced patient cues to guide timely intervention. Real-world scenario, trauma. Picture a 25-year-old male from a motor vehicle accident with multiple fractures. He's hemodynamically stable, blood pressure 120/80, SpO2 96% on 2 liters, but has facial swelling and needs surgery for a femoral fracture. Though stable now, anesthesia and positioning could worsen airway swelling or cause bleeding, compromising patency. Preemptive intubation before the OR ensures a secure airway during the procedure. Use rapid sequence intubation with cervical spine precautions given trauma risks. Waiting until he decompensates in the OR is too late. Proactive intubation here prevents an emergency. Alternatives like monitoring may work only if surgery isn't imminent. Again, this goes back to some of the art of medicine. Real-world scenario, sepsis. Now, imagine a 55-year-old female with pneumonia and early sepsis, fever, tachycardia, and tachypnea with a respiratory rate of 28. Her SpO2 is 94% on 4 liters nasal cannula, and she's alert. She's stable but at risk for respiratory failure as sepsis progresses. A BiPAP trial at 10/5 centimeters H2O can support her breathing while antibiotics and fluids kick in, avoiding intubation if she stabilizes. Monitor vitals. Worsening respiratory rate greater than 30 or hypoxia may necessitate intubation. This approach balances early support with the chance to avoid invasive measures, common in sepsis before full decompensation. Brief overview of airway assessment. Lemon criteria. The Lemon criteria helps assess airway difficulty before intubation. L. Look externally. Facial trauma or a thick beard can obscure landmarks or mask fitting. E. Evaluate the 3-3-2 rule. Can the patient fit 3 fingers between incisors to check mouth opening, 3 from chin to hyoid to assess the submandibular space, and 2 from hyoid to thyroid to assess laryngeal position? Deviations predict trouble aligning axes. M. Malampati score. Class 1 tonsils visible is easy. Class 4 only hard palate is tough. O. Obstruction. Swelling from anaphylaxis or a tumor complicates tube passage. N. Neck mobility. Arthritis or trauma-limiting extension hinders laryngoscopy. A high Lemon score might push you toward awake intubation or video laryngoscopy over standard rapid sequence intubation. We will talk about pre-intubation airway assessment in more detail in another presentation. Anatomy of the larynx, intubation view. The larynx sits between the C3 and C6 vertebrae, just anterior to the esophagus. It's critical for protecting the airway and enabling speech, but during intubation, we're focused on its role as the gateway to the trachea. When you insert a laryngoscope, the first thing you'll see is the epiglottis, a leaf-like structure at the tongue base. Lifting it reveals the aryepiglottic folds framing the laryngeal inlet. Below that, the vocal cords appear as white, horizontal bands. The gap between them is the glottis. That's where the endotracheal tube needs to go. Posteriorly, you'll spot the arytenoid cartilages, which may have small bumps from the corniculate and cuneiform cartilages. Depending on the blade, McIntosh curves into the vallecula to lift the epiglottis indirectly, while Miller lifts it directly. You'll align the oral, pharyngeal, and laryngeal axes to get a clear shot at the glottis. Practice makes this smoother, but anatomy varies slightly, patient to patient. Airway anatomy will be revisited again in another presentation. Summary. This concludes the presentation on indications for intubation. In summary, intubate for airway obstruction, protection against aspiration, failure to ventilate or oxygenate, or when deterioration looms. The Lemon criteria predict challenges. Use them before every attempt. Laryngeal anatomy knowledge ensures accurate tube placement. We've covered scenarios showing intubation's necessity, like ARDS or trauma, and alternatives like non-invasive positive pressure ventilation in milder COPD or congestive heart failure. Ultimately, mastering intubation combines rigorous science with the art of medicine, where data-driven decisions intersect with the subtleties of patient care. It demands not just technical skill, but a deep understanding of when to act, guided by both evidence and instinct. This balance allows us to adapt swiftly, ensuring each patient's unique trajectory is met with precision and empathy. Thanks for listening.